Hi, everybody. Good evening, good morning, good afternoon, wherever you are. Welcome to this new journal club by the International Academy for Clinical Hematology. It's almost roughly 7 p.m. in Paris, 7 p.m. in Palermo, in Sicily, 8 p.m. in Beirut, and 1 p.m. in New York. I'm Mohamed Moti from the Sorbonne University and Saint Antoine Hospital in Paris, and it is my great pleasure to moderate this journal club today, which is, as usual, supported by an unrestricted educational grant. The Scientific Steering Committee of the IACH has chosen this recent paper published in Blood on the 15th of December by Dr. Roberta di Blasi. And Roberta di Blasi is a consultant hematologist at the St. Louis Hospital lymphoma unit, headed by Professor Catherine Thiablemont. And Roberta has been involved in this CAR T-cell field since the first trials that were introduced in France. And this paper published in Blood was an analysis based on the French National Registry of CAR T cells called DESCART. And this is about the outcome of patients with aggressive B-cell lymphoma after failure of the anti-CD19 CAR T cells. And you can see here the abstract of this paper that we will discuss with Dr. Di Blasi and Professor Bazarbachi, who is a professor of hematology at the American University of Beirut Medical Center. He is well known to all of you. He is the secretary of the IACH, and is much involved in the innovative treatments for lymphoma. So to make a long story short, Dr. Di Blasi and colleagues analyzed 550 patients registered in this national registry and who relapsed after CAR T cells, because obviously, despite the enthusiasm we have for CAR T cells, a significant proportion of patients continue to relapse despite the infusion of CAR T cell. And actually, when it happens relatively quickly. That was at a median of 2.7 months, less than 3 months, but it can go up to almost 2 years, 21.5 months. And in this work, the authors nicely actually managed to capture the different salvage therapies that were given to these patients who failed CAR T cells. And you will see that it is quite impressive to see the heterogeneity of the practice. And this is only in one country, in France, which really highlights that we are facing a true lack of guidelines and standard practice on how to manage these patients. One interesting, and we'll discuss this, I'm sure, with the panel, one interesting parameter is the popularity, actually, of the use of lenalidomide. So it looks like there's something there where the community is convinced that maybe IMiDs are able to stimulate CAR T cells. And here you can see I would say, disappointing progression-free survival of these patients after failure of their CAR T cell, a very dismal outcome, actually. And this again highlights the need to develop novel approaches. Interestingly, there are some significant differences when it comes to PFS depending on the timing of relapse. And those patients with a very early relapse, the red curve, are doing worse than the patient with, I would say, a later relapse beyond day 90. But someone may tell me that actually this simply reflects the kinetics of the aggressiveness of the disease, and nothing is unexpected there. So with this, I will stop. And as it is always the tradition in the journal club, my first question will be for you, Professor Bazarbachi, because you are not a co-author of this work. So I would imagine that you have discovered this at time of publication. What was your reaction? Was it something like, oh my God, we believe CAR T-cell are curative and actually it's a disaster and we're wasting a lot of money on this? Or the glass is not half full or half empty, but you would say rather, anyway, we're curing a significant proportion of these patients and we still need to work on the other proportion. Just share your thoughts.
Good evening, everybody, and thank you, Mohammed, for the kind invitation. So actually, I would say the glass is more than half full. CAR T cell, there is no doubt that CAR T cells have changed the landscape of treatment of aggressive lymphoma, particularly relapsed refractory lymphoma. So even though the latest data from last year ASH and also confirmed this year are showing that CAR T cells may be superior even to autotransplant for primary refractory or first relapse, I believe that the majority of the patients included in this trial, if not all of them, are beyond this. I mean, most of them had more than 3 prior lines to treatment. So the fact that half of the patients who received CAR T cells were relapsed is something that was not unexpected, because multiple other series worldwide have shown the same. And the fact that their outcome post-CAR T is dismal actually is also expected. And I would say that these patients, this outcome is similar or even better to those of the Scholar data for patients who did not receive CAR T. So these are the worst of the patients who received the CAR T. These are those who were not cured by CAR T, and yet their outcome is similar to those relapse refractory who not. So rather than saying that CAR T, that patients are relapsing after CAR T, I think that the merit of this publication stems from 2 major points. The first is trying to predict which patient will relapse and will relapse earlier, and what are the predictive factors for poor outcome after relapse after CAR T, including the early relapse, very early relapse, the high LDH, etc. And the second merit, I would say, is related to exploring the treatments and their efficacy after relapse after CAR T, including, as you mentioned, lenalidomide, which is the most easy to use, readily available. The fact that conventional chemotherapy did not work well, this is not unexpected, particularly that the patients are refractory, and bispecific, but unfortunately only 11 patients because received this treatment. I think that this was recently introduced.
Thank you. So you have rather a sort of a positive, I would say, assessment of the analysis. So, Roberta, before going into the details of the paper itself, I thought just to clarify to our audience, what are today the current indications in your center, but in general, for CAR T cells, for anti-CD19 CAR T cells in lymphoma? Because I think Ali mentioned already, first relapse and, the results compared to auto. And we had in this journal club discussed previously the randomized trial, one of the Zuma, I think Zuma 7, randomized trial showing the superiority of CAR T cells. So what are the current indications?
So yes, good evening, everybody. Thank you, Professor Moti, for inviting me here and for your nice introduction. So yes, actually in Europe, the current indications are relapse refractory DLBCL after 2 lines of treatment. This was up to September last year, September 2022, when we can use also axi-cel for patients that relapse within 1 year. It was initially just for young autotransplant eligible patients, and later on this indication was enlarged for also transplant ineligible patients, also elderly patients, but fit, according to the results of a recent French study in the LISA, it was Alicante study. This is the indication in France. We also have, of course, the CAR T cells for relapse refractory mantle cell lymphoma for a few years now. And for a year, we have been having also the indication for follicular lymphoma, relapse refractory follicular lymphoma. So we can currently use CAR T cells, anti-CD19 for these 3 indications in our center.
Okay, excellent. So now, one question, and you alluded to this, Ali, and both of you, I think you can comment on this. It looks like there is a common belief in the community that lenalidomide, for instance, and IMiD in general, and I guess this is because of their immunomodulatory activity and because there are some prior publications highlighting that they may induce CRS, the cytokine release syndrome, after CAR T cells. It looks like they are quite popular in this field. I mean, one explanation, Ali, you mentioned because they are oral drug easily available, but I'm not sure that's it's about ease of access. So how do you, what's your interpretation of the use of lenalidomide there? Is it about to try to re-stimulate the proliferation of the CAR T cells, or if it's just about the anti-lymphoma activity?
Thank you, Mohammed. I think this is a very important question, and I will try to be brief, but pointing on 2 aspects of that. The first is that the use of lenalidomide for refractory lymphoma, particularly refractory diffuse large B-cell lymphoma, has been there for maybe a decade. And in many hematological malignancies, and we discussed that before, lenalidomide has been used as the Swiss knife for relapsed refractory patients. And we all have in our practice patients refractory to everything and who achieved remission, and importantly, long-lasting remissions after lenalidomide. And the second aspect is the immunomodulatory effect of lenalidomide that can have both a direct action on the lymphoma, but also can stimulate the CAR T. Of course, it's difficult from this paper to judge which aspect of lenalidomide achieved the remission, but I think that these were thinking, maybe, I believe, behind the use of this drug for patients who relapsed.
Roberta, are you using actually lenalidomide for salvage in these patients, or at least are you using it for any group of patients?
Yes, actually, we the reasoning that supports this choice is that lenalidomide can increase the strength of these immunological synapses between the tumoral cell and the CAR T cell. This was based in some in vivo study, one in vivo studies, and this is why we tend to use this recently. We tend to use this in a very early phase of the disease. So yes, this is why we use lenalidomide when we think there is still some activity of CAR T cell that we can exploit. And yes, I would say that we use this kind of activity, the immunomodulating activity, rather than the anti-lymphoma, anti-tumoral activity. Yes, so we do need that. We do know that this is very experimental yet, but a trial that is going to be done, I hopefully in the context of the LYSA group, will use the lenalidomide in the peri-CAR T setting. So really after the CAR T infusion. So we hope to start with this study as early as possible, and this is something that is currently preparing. So we are going to study this phenomenon in a more thorough way.
But this is interesting, and my question to you, Ali, what would be your reaction to this? Because one of the greatest advantage, and I always listen to patients, they are very happy receiving a sort of a single shot treatment. But now, according to Roberta, the idea is that to give CAR T cell, but then give maintenance therapy after it. So we would lose this, you know, fancy thing of having a single shot curative treatment. So what are your thoughts about this?
So you made my day, Mohammed, by asking me this question. So actually, I believe that we are, even though CAR T cells have been here for some years, we are still in the early years or infancy of CAR T cells. And we went through the same reasoning and same question for stem cell transplant, for auto transplant, and for allogeneic transplant, where initially it was thought to be the last line of treatment and patients are cured. But now the field is moving and toward maintenance treatment after transplant. Lenalidomide in multiple myeloma, brentuximab consolidation in Hodgkin for auto, as well as TKI in Philadelphia positive ALL or FLT3 AML. So my reasoning when or my thinking when I saw this manuscript and was rather than waiting for relapse after CAR T, particularly for patients in whom we have predictive factors for relapse, such as the high LDH before using the CAR T, or the metabolic tumor volume or other. I mean, since we know that these patients are at least 50% risk of relapse, if not more, for many of them, about using lenalidomide as maintenance treatment to try to prevent relapse rather than to use it to treat relapse when it happens.
So we have a few questions here about how to predict relapse, Roberta, in these patients. And I don't want to be rude, but for instance, the paper states that those with a high LDH level are likely to relapse more. But this is just a surrogate marker of having a more aggressive disease. Another parameter is that those patients who relapsed very early within the first months are not going to do well. And someone would say, and so what? So don't you think we need, and that is a question, more robust, more specific parameters to try to predict those patients who are going to relapse very early? Or on the other hand, there is another question from the audience about, should we exclude actually these patients from CAR T cells because we know they're not going to do well?
Yeah, sure. This is a complex question. Even though simple is complex answer to this question. Yes. So sure, I totally agree with the fact that the parameters that were put in evidence in the paper were the surrogates of a very uncontrolled disease. So we can expect that an uncontrolled disease, it's something that puts the patient in a more likely situation of progressing. So that I do agree. We did not expect that the prognosis of the patients relapsing within the first 30 days would be so bad, actually. So this is kind of something that we can argue. And of course, as you said, how can we predict in first place the patient that will relapse and will not respond well to CAR T cells? So in another French publication that were made in 2021, we pointed out two parameters of potential risk factors for relapse in patients treated by anti-CD19 CAR T cells for DLBCL. So we know the total metabolic tumor volume higher than 80 ml can be one high risk parameter. So we know that patients presenting a high metabolic tumor volume at the moment of lymphodepletion will be more likely to progress and not respond well to CAR T cells. And then another parameter is the presence of 2 or more extranodal sites also at the moment of lymphodepletion. So these are 2 parameters that, when present, can really influence the PFS of these patients. Either 1 or 2 of them can really put the patient in a different situation. So 2 situations here to discuss. Would I propose CAR T cells to a patient which is very proliferative even before the bridging therapy that I can propose to him or her? Well, it's difficult to decide because we could improve the post-CAR T or peri-CAR T treatment afterwards, but I wouldn't probably not candidate to CAR T cells a patient that is really rapidly progressive and with a really high tumor bulk and with a really high number of extra nodal sites. Then there is a patient that can arrive at lymphodepletion with a volume that is higher than 80, which is the threshold that we pointed out, in which I would suggest, this is precisely the setting that you were talking about, Professor Bazarbachi. It was exactly the setting. We exactly what we do for patients that are at high risk. We propose an immunomodulation with lenalidomide in the first days, not for a curative purpose, but with a immunomodulating purpose.
Can I ask you here? We have another question. I don't know. Both of you can respond to this. We know that there are several CAR T cell constructs today for the same indication. And I mean, it's not true in every place, but assuming, is there, and there is a paper published also a few months ago, Roberta, I think you were co-author of this work, from the Discard, suggesting some differences between CAR T cell construct. So do we believe, are there any indications from this paper that one construct can do better than another, or we can't actually draw any conclusion?
So my first impression when I read the paper, reading in table 1, was that even though we had much more patients who received axi-cell than T-cell cells, the early relapse below day 30, more than 60% of them were with T cells. So conversely, the late relapse were much more frequent with axi cells. So so that gave me the impression is that maybe for patients with a very aggressive disease, there is a difference between the products.
Roberta, do you agree?
Yes, so I quite agree with this. So we do know with the recent paper that was published by Emmanuel Bazarbachi, also in the discard setting. So we have basically the same patients here. There was this study that by the use of a pairing system to erase and to level the differences between the patients included in the discard registry receiving axi-cell or T cell. So we could conclude that axi-cell did better than T cell for in terms of survival, PFS, not yet in the duration of response. To answer to your question, but yes, in some way it did better. However, in the discard registry, the two parameters that I was just talking about earlier, TMTV and number of extranodal sites, were not that well elucidated, so we're not in the database. So yes, we do not know exactly what would happen if we included these two variables in the setting of the paper of Emmanuel Bazarbachi. To my opinion, in a very practical way, yes, I assume that if I have a young patient with a high metabolic tumor volume and a very aggressive disease, I would be more confident in using axi-cell product. And yes, I think I would do that. However, if I had an elderly patient with with a small metabolic tumor volume and with some comorbidities, for instance, I think I would rather go for the T cell product, because the tolerability profile is different anyways. Yeah.
Okay, so let me move a little bit beyond this paper and take a question which I believe is a very good one from a member of the audience about the use of bispecific antibodies, because this paper, if we look historically, CAR T cells were approved before actually bispecific antibodies and T cell engagers. And actually, maybe if we do the same study, Roberta, in 2 or 3 years, we will see maybe more bispecific antibodies as salvage, or even more patients will receive bispecific antibodies before CAR T cells. So Ali, my question to you, and this is a question also from the audience, whether today, if especially that not everybody has access to CAR T cells, so assuming you have the different options, would you use bispecific antibodies, for instance, in some patient who are pre-identified before CAR T cells, or you would rather stick to CAR T cells first? And then I'll ask the question whether we should use bispecific antibodies after CAR T cells, because a few minutes ago, both of you tried to convince me that IMiDs are maybe the best option, but why not bispecific antibodies for consolidation or maintenance?
Because we don't have them. I mean, thank you, Hamad. I think this is a very important question. The efficacy data, and particularly at the last ASH meeting, is also quite impressive with bispecific antibodies, particularly the CD20, CD3 bispecific T cell engagers. So the issue is that currently they are not available, commercially available. They are available within clinical trials, and I think that even when they will be registered initially, they will be registered I mean, CAR T cells will soon get approval second line, if not the case in many countries. And then the bispecific will be in third line, but this is just a regulatory and approval issue. So now, if you ask me the question differently, if the all products are available, we can use them, they are reimbursed, then definitely having a product in the pharmacy readily available, that if I prescribe now the product, in 30 minutes the patient will be able to receive, which is the case with bispecific, then my guess is that many centers will be giving the bispecific first, particularly if the efficacy is thought to be similar, even though I doubt that we will have soon randomized trials of CAR T cells versus bispecific.
So, Roberta, would you adopt the same approach as just been described by Ali?
Yes, I mean, this is a difficult question, and I'm convinced that maybe we could only answer with that by some time and with randomized clinical trials. For the moment, I would say that for DLBCL, our practice is also because bispecifics are available only in trials. So this is, of course, the most part of the problem. So we actually use before CAR T cells and then bispecific. It's true that in the recent ASH meeting, we've seen many bispecific antibodies used in relapse refractory B-cell lymphomas in general, with very encouraging results. And yes, they were useful in pre-CAR Ts, in CAR T naive patients, and in CAR T non-naive patients. So this is something very, very interesting. I think that I can say is that the injection, the administration plan of these molecules was slightly different in between the molecules. So I think that this is really important, because we were, for instance, epcoritamab in the EPCORE study that was used and with no limit of time up to progression or toxicity. So I think that would really make the difference between one treatment in one shot. So I think that this is very important. Other bispecific antibodies were used for a lapse of time of 1 year or less, as the glofitamab, for instance. So I think that this really makes a change in the choice for the clinician and for the patients. And I think for us, it's quite clear in the DLBCL, we do before CAR T cells and then bispecific if relapse. I think that the pathology, if I am going a bit further off the topic, you tell me, but I think that, for instance, follicular lymphoma is really a hard question when the patient comes to you for CAR T eligibility and tells you, but should I maybe receive another treatment? And I say, oh, yes, maybe there is another treatment that can be used. And that's more difficult. In this situation, I really try to tailor around the patient more than for the LBCL, for which in our clinical practice, the algorithm is quite straightforward.
But okay, let me ask Ali the same question in a slightly different way. From an immunological standpoint, my best guess is that if you use T-cell engager, you may end up having T-cell exhaustion. So although, Ali, you advocated that bispecific are available off the shelf immediately, but then if you try to do your CAR T-cells and collect your lymphocyte later, you may not, at least theoretically, have the optimal or right product. Although I must admit that we still don't know what is the right composition of the soup that is being used to manufacture these commercial CAR T cells, because we simply do an apheresis, takes the lymphocyte, and we don't control. I mean, there are trials, there are constructs trying to control for the content. What are your thoughts? Because that can also bring to the idea saying, okay, maybe we should collect lymphocytes and
Absolutely,
store to everybody.
that was the answer I was going to give. I mean, you gave already the answer in your question, Mohammed. So basically, I believe that patients who are if we have the possibility of using either CAR T cells or T cell engager bispecific antibodies, one smart way would be to collect the lymphocytes, to cryopreserve the lymphocytes, like we do, for example, in multiple myeloma patients or receiving lenalidomide. I mean, induction, you harvest the stem cell, you freeze them, because lenalidomide is harmful to the stem cells. So if bispecific or T cell engagers are harmful to T cells through exhaustion of T cells, we can collect the lymphocytes first, cryopreserve them, give the bispecific, preferentially using bispecific that are different from the CAR T. So for example, Roberta mentioned glofitamab, which is a CD20, CD3. The CAR T are anti-CD19. So that will also prevent resistance through downregulation of the CD19 or the...
Okay, wonderful. We have two questions for you, Roberta, from the audience. One is about, I think that was Dr. Farhan, about the use of antibody drug conjugates in this setting. And there is another question about why not, if you have failed one CAR T cell construct, why not using another different CAR T cell construct, especially if there was no proliferation after the first CAR? What would be your answer to these two questions?
Well,
antibody drug conjugates and then the second CAR.
Yes, I'll start with the second question. Actually, we in our clinical practice, we almost never did twice the injection. We did once. As for the recovery CAR T dose, because the first dose was a bit below the limit, so we wanted to try, but we did not improve any result with the second injection of the same product. So yeah, it was not very interesting results. The patient was then rescued by specific in this very special case. And with the two products, I think that we only did that once. And it did not show any improvement either. We also know from our leukemia clinicians that they almost had the same results in ALL patients with a second infusion of CAR T cells. So this, I can say that this is not practice at all. And for the conjugate antibodies, so actually we did not. I know that other studies that were made at the same time of our study in the US and Israel centers almost gave the same results. So it seems interesting to propose chemotherapy to patients relapsing after CAR T cells. A slight difference was observed with polatuzumab, which has the reimbursement in other countries, but that as not in France. So we can use it, but it's not reimbursed. So this is why we maybe use just once this drug. And so this is why I have not any personal experience on that. And yes, there are some other molecules that are in France also in clinical trial, in clinical assay. So of that, I also do not have any great experience, but yes, it happened to us to rescue a patient with locastuximab and ibrutinib in a clinical trial. So yeah, actually, I think that we can propose these drugs, but I don't have any experience on very personal experience on that. Sorry.
Okay, one last question to you, Ali, before I ask Roberta the next step. This is how it works in the Journal Club. The author of the paper will give the next step after this work. But my question to you here is that usually in hematology, we believe that if you want to improve the outcome of the patient, actually, and if you have in hand an effective treatment, you'd rather use it earlier in the course of the disease. And here we were talking about relapse refractory, almost end stage patient. So today, do you see any role, Ali, for the CAR T cells in an early stage of the disease? And then maybe we can avoid some of these disappointments. There is also, although we did not discuss it, a sort of a cost effectiveness parameter here, because obviously giving a CAR T cell product with thousands and thousands of euros or dollars for a median time of relapse after 2.7 months, definitely the health systems will face some challenges. So what do you think about the early use? Just a speculation on the ideal scenario or trial you would like to run.
Okay, thank you, Hamad. So first, what we mentioned in the beginning of this journal club is that already we have data from 2021 ASH meeting about earlier use of CAR T cells, I mean in second line for primary refractory patients, as well as early relapse after first line treatment in diffuse large B-cell lymphoma. So this is much earlier use than the patients that were included in the blood paper of Roberta that we just discussed. So now if the question is to move even earlier to first line, I think that this is a more tricky question, because currently whatever we do, we are curing most patients with diffuse large B-cell lymphoma. So maybe a trial that can be run is about is similar to the French trial for a PET-directed therapy, whereby autotransplant was proposed for patients who did not achieve adequate delta SUV after 2 cycles or 4 cycles of chemoimmunotherapy. So maybe a similar trial can be, if you want something, I mean, about use in first-line treatment, I would say maybe for the slow responders or patients who don't achieve, if CAR T are more tolerable than autotransplant, then this would be the setting where we can think about a clinical trial in first line.
Excellent, very brilliant perspective. So Roberta, again, congratulations for really wonderful achievement and paper in Blood. I think it's quite unique, but the question is, what are the next steps? Where are you going to take this work to? The conclusions, how are you going to build on these results?
Yes, so one thing that was our field of interest was to differentiate the patients that relapsed early within the first 3 months from the other patients. So we saw that in the curves, that the patients presenting very early relapse show worse prognosis. And we also kind of have the feeling, and the pivotal studies, of course, show this to us, that after CAR T cells, you kind of achieve a kind of a plateau. So when you achieve the response, late relapses are rare. So one field of interest of the discard group and our group in particular was of the late relapses. If there were some particular clinical and eventually also histological and biological parameters that are to take into account and to differentiate the patients that relapse early and late. I think that this is going to be the use of bispecific CAR T cell antibodies for relapsed CAR T cells patient with a number higher than the 11 that we treated with CAR T will be very interesting in a real life setting. And yes, of course, the other thing for me that is important is to determine the efficacy of CAR T cell in second line. Now that we have this early use availability since September last year, and we started to treat a bunch of patients in second line with all the consideration that we can do, as you said just earlier, with the performance of T cells, etc., the susceptibility to chemotherapy of the patient. So I think that second line real life will be really important to know. Yeah.
Wonderful. Well, I think that was really lovely journal club. Thank you both for sharing your thoughts. I think this field of immune therapy in general, whether CAR T cells, whether T cell engagers with bispecific, but also even trispecific, whether innate immunity engages, is really fascinating. I'm convinced that this is a true revolution in the field of hematology and cancer in general. But I think the work published by Dr. Blasi is clearly highlighting that we're still not curing all of these patients. And this is why we need to continue to work very hard on developing more and more options for these patients, because at the end of the day, the most important goal, of course, is about curing these patients. So thank you both for your efforts. Apologies for all colleagues where I could not take all the questions. We're already running a little bit out of time, but I hope you have enjoyed it very, as I learned a lot from our both panelists, Professor Bazarbachi and Dr. Blasi. And I hope to see you soon in another journal club, but also many IACH activities. I believe we do have a couple of post-ASH webinars dedicated to CAR T cells very soon. So with this, I'd like to thank you for your attention, and wherever you are, please stay safe and keep well. Take care. Bye.
Thank you.
Bye.
Good evening.
Bye, everybody.
Bye-bye.
Bye.
Goodbye.